So, hi everyone, this is Denise Wilson. I'm your host and mostly just your host today for our second in our Sepsis Appeal Workshop series on sepsis denials and appeals. This webinar is being sponsored by a joint sponsorship by PayerWatch and by the Association for Healthcare Denial and Appeal Management. In today's webinar, we have Dr. Edgar Agvanyan from Adventist Health as our special guest, and he's going to be discussing documenting sepsis in a singular way. We also have Garnette McLaughlin and Christi Drum here to provide insight on appealing sepsis denials, both from a coding standpoint and from a clinical validation standpoint. Our last workshop in our series, workshop number 3, will be next Wednesday, September 28th at 1 p.m. Dr. Hasabala from Sound Physicians, Dr. Kendall Smith, and myself will be presenting on that webinar some additional aspects in coding and, in appealing denials for sepsis. And you can register for that third workshop if you haven't already at www.payerwatch.com. So if you're not aware, September is Sepsis Awareness Month, so you should be aware. And we, PayerWatch and AHDAM, have joined forces together to present this 3-workshop series on sepsis. Sepsis is the leading cause of death in U.S. hospitals, and having that lack of consensus on the definition between payers and providers is causing a lot of concern over how do we document sepsis, how do we defend sepsis in our documentation, and also how do we make sure that we identify and treat sepsis quickly and early in the process. So please consider supporting the Sepsis Alliance, and you can learn more at sepsis.org. Dr. Agvanyan is our special guest speaker today. He is the System Director for Case Management and CDI for Adventist Health in California, Oregon, and Hawaii, and we keep teasing him that we need to come visit him on his trek to Hawaii next time. So far, we haven't received that invitation, but I'm sure it's in the mail. Garnette McLaughlin has more credentials than I can possibly speak of. She is our coding expert as well as our compliance officer at PayerWatch and does a lot of education around coding. Christi Drum also has a good number of credentials behind her name as well, and she is really a CDI expert and works for PayerWatch as our clinical appeals expert in clinical validation. Okay, we're going to jump right in. I'm going to go ahead and turn control over to Dr. Agvanyan and let him start his presentation. So give me just a second. Let me give you control. Okay, Dr. A, it should be all yours.
All right. Good morning, everyone. Well, good morning and good afternoon for those of you that are on the East Coast. I'm in California, so that's why I say good morning. I'm happy to be here with our friends at PayerWatch. So today I'm going to be talking about our approach to sepsis and what Adventist has been doing and go into a little bit of detail as to why. The approach that we've taken currently with our sepsis is following the Sepsis 2 criteria for sepsis as a result of CMS rules and the Medi-Cal rules here in California. As a result of the SEP 1 bundle and the value-based purchasing and what that means for our organization of 22 hospitals right across 3 states, we've decided to approach it in this particular fashion. Our number 1 approach has been denial prevention. Right, and how we've been doing that is creating specific targeted education to our frontline physicians, to our CDSs, right, in improving documentation from the front door, starting from the emergency room, and being able to capture the necessary clinical information and validating the chart so that we don't end up in a denial. So denial prevention is what we're currently concentrating on. And, with clinical validity of our queries, trying to get our doctors to document with a rule in, rule out, treat and resolve type of diagnosis and consistency within their charting from ED to discharge.
And let me interrupt for just a minute. I'm sorry, I forgot to let you all know that you can download the slides from the control panel that you have through GoToWebinar. Go to the handouts section and you can download the slides and follow along. If you have questions for us as we go through, please put those in the questions box and we will have a question and answer at the end. Sorry, Dr. Agvanyan, go ahead and continue.
So, again, just more of the focus on, don't allow it to get to an audit or denial, right? As you all know, there's a lot of work and effort and time that goes into denials and appeals after the fact. And if we can get this done correctly, on the front end, I think it's going to save us a lot of work. And so that's why we're sort of concentrating so much of our efforts. It's always great to have an overturn or a denial, but if you can, concentrate your efforts onto preventing them, even better, right? So we can work on, other things that are a little bit more important than fighting insurance companies. So the approach that we've taken is documenting a singular way. And when I say that, what I mean is, 22 hospitals, multiple hospitalist groups, community physicians, and a lot of our hospitals that admit their own patients. So when thinking about how to best approach this, we decided to take the SEP1 bundle, the criteria of sepsis, to create education tip sheets around it and start disseminating that to our hospitals. We're currently doing that through our physician advisors. We have a physician advisor program. Each facility has a formal physician advisor assigned. And with the help of the physician advisors, we're bringing in the hospitalist groups and creating monthly educational sessions on whatever trending topics that may be going on related to denials, CDI, and sepsis has been our priority over the past couple of months. We do have a few contracts where we are obligated by contract to use Sepsis 3 and the QSOFA scores. We choose not to teach that particular market or where that contract is to code it differently based on payer type. We like to just teach our CDIs, the coders and physicians to code and document singularly and be consistent, so that we're not confusing folks and they're just treating patients based on whatever condition is presenting rather than trying to treat to the contract or the payer. So again, for simplicity's sake, we go with the SEP1 bundle, Sepsis 2. That's what CMS is using, so that's what we decided to go with. It's our approach as an organization. In California, for those of you that are not in California, we do have a little bit of a complicated system. We have a lot of delegated and managed groups and HMOs specific to the Medi-Cal system and the commercial plans. And each one of them has their own contract nuances and requirements. And so with the government payers being the largest that we deal with, we chose to go with this particular approach. So the next question comes up, well, with all those delegations and all the different contracts, what do we do? So, previously we had, hundreds, if not thousands of different types of contracts per medical group, per IPA, per HMO. So what we're doing now is going through with the top 5 payers that we have. We just finished the contracting with Anthem. We're in talks now with HealthNet and United Healthcare, is trying to have universal contracting, right, for all 22 hospitals relevant, to the state. Changing the contract language so that we agree with the payer on what we are going to be looking at together. It would be unfair of us to try and fight United on Sepsis 3 if we agreed to Sepsis 3 rules, right? And so, because they're going to turn around and say, well, contractually, this is what you agreed to. So when these contract negotiations are coming up, we're putting a lot of effort into showing them why, right? Presenting the information necessary, the denials, how long it's taking to have these overturned, to leverage, the size of our market, the size of our system to try and get some contract language terms that are in our favor or favorable for both, so that, we're playing on the same field. But what does it mean to embrace, sepsis 3 at the expense of the CMS bundles? To me, and Dr. Smith and I have gone back and forth, and we've talked about this so many times, it gets kind of confusing, right? So how do you stay with the value-based purchasing that CMS is requiring, and CMS using the Sepsis 2 criteria, but at the same time, you have these payers imposing upon you Sepsis 3, right, which doesn't coincide with how you work as a system. To us, we want to, the anecdotal evidence for us has shown that, and I couldn't pull the numbers, in time for this meeting, but about 82% of sepsis in our emergency rooms presents as POA. And so if sepsis is presenting as POA, we don't want to wait 6 hours, before we can call this sepsis, right? We get a sepsis alert that kicks off, and we treat towards that sepsis. So we may be catching more patients than necessary in that situation, and at times, and this is where the documentation piece comes in, where we try to teach our physicians that if early on in the process you determine that this was not sepsis, then you document so, right, saying that it was initially triggered as a sepsis alert, secondarily it was either treated or it resolved, or is no longer sepsis, and you stop documenting it. Because oftentimes what we find is you get a single sepsis diagnosis in the ED, it doesn't carry through on day 2, day 3, and discharge, then you get a denial, right? And so again, coinciding with our quality initiative, year over year, we've seen a significant reduction in our sepsis mortality O to E by using the approach that we have. Again, as a result of sepsis being POA on most of our accounts that come in through the emergency room. Documentation again. You're going to hear me throughout my presentation say documentation, documentation, and I think some of the folks that deal with CDI will appreciate the fact that, whether you're coming from CDI, whether you're coming from coding, CDI query, coding query, it essentially comes down to documentation. All of you that have been on calls with payers and plans or come from that world, that when you're talking to a counterpart on the other end, first thing that they ask about is, well, what was documented? How was it documented? And does the documentation justify the actions taken? So, as you know, some of the rules in 2023 with billing and coding are going to be changing for physician documenting, right? Putting a heavy emphasis on the complexity and the justification of the decision making. As a result of this, if we're putting down a diagnosis, just simply putting it, I think that we are going to be dealing with even more denials unless we concentrate on justifying that diagnosis, right? Telling the story correctly as to why, what potential complications and complexities we may be facing with, because this is, what the payers are going to be looking at starting in 2023. So part of the educational process that we're putting forth is getting our doctors not to just put down a sepsis diagnosis or copy and paste forward their progress notes, from one day to the next, but actually, forcing functions upon them and not allowing them to have those copy and paste functions, so that when they're putting an assessment and plan in place, they're having to go in and type something out, right? Forcing them to think about the decision making and the justification of why they're putting that as a diagnosis. In our, we have, all of our facilities have room for improvement. It's a difficult challenge we've taken upon. It's very difficult to change physician behavior and how they document. Some EMRs allow for physicians to continue, poorly documenting because of copy and paste functions. Where we can, we're automating. We're trying to make sure that we turn off those functions within our Cerner EMR system. That's the current one that we are. Our goal is to eventually transition everyone, including specialists, to what is called the dynamic documentation type and within Cerner, which does not allow for that copy and paste function and doesn't have pre-filled progress notes, and actually will force everyone to go in and type in an HPI each and every time, along with an assessment and plan. what we've done on the back end for those payers, like we have a particular payer, HMSA and United Healthcare, specifically in Castle in Hawaii, where Denise wants to have our next meeting. And I'm working on that. So we'll try to get everybody out there one of these days, and Kendall will appreciate that as well. I'm yet to go out there myself, and that's why the meeting hasn't happened yet. So, but in that particular market, over the past, I would say, year, we've had approximately $500,000 in denials when it comes to sepsis for that market. And when we think about the hundreds of millions of dollars that we're dealing with on a yearly basis, even though it is a good chunk of money, it's a small drop in the bucket for us to have to change and try to teach those folks there how to document differently than everyone else. So that's why we've kind of stuck with our singular approach, and we've done a case-by-case appeal on those that we do get appealed. And oftentimes, because we are finding reasonable physicians on the other end with the medical plans, and we're able to show them the evidence that this was truly sepsis, we are able to overturn those. It is taking a little bit more work, and hopefully with contract negotiations, we can get some of that changed around. So again, as a physician, right, if knowing, the appeals process and denials team, what is required helps for us on the back end, but not on the front end, right? For a physician taking care of a patient in the hospital, we just want them taking care of those patients in the hospital. We don't ever want anybody thinking this is a United Healthcare patient, so I have to document differently. I have to delay the sepsis alert. I have to wait 6 hours versus getting it in within the first hour or the first 3 hours. And so that's not the type of approach that we want to take ever. So a couple of things that came up. Questions that have been asked is, if we're using Sepsis 2 and we are capturing more sepsis on diagnosis, what does that do to our CMI? Well, so by taking the appropriate documentation approach, it has bumped up our CMI a little bit, but not in a way of trying to game the system. Again, consistency, right? If we are consistent in how we query for sepsis each and every time, using the same clinical indicators, if we're consistent in how we document sepsis each and every time across all 22 of our hospitals, then we aren't gaming the system. We're just being very consistent, and we can show that tracking of that consistency within it, that we're doing this a singular way for a reason, and it applies to most, maybe not all, but the consistency definitely matters. Within this sort of method of approach, one example that I'll give you, in one of our largest markets, our flagship hospital, 450-bed hospital in Glendale, over the past 2 months now, we've been taking a strong approach with the education. The 4 initial topics were sepsis, encephalopathy, malnutrition, and AKI. Those topics are not a surprise to anyone on this call. You all know that those are the ones that get looked at and audited most often. So we wanted to make sure that we were getting this properly. Within a single month, our CMI bump up was from 1.96 to 2.1, which is huge, right? So that translates to approximately $600,000 to $700,000 a month of reimbursement for that hospital. And if we can keep that up by, the continued education initiative that we've taken on, teaching our hospitalists, and we're now starting to teach our specialists as well. We're having our physician advisors and the CDI teams meet on a regular basis with cardiologists, with anesthesiologists, and with surgeons to be able to capture and have them start thinking about the ramifications of their documentation and what it means to capturing those CCs and MCCs, and painting an overall picture for the plans that this patient was as sick as they were. So.
Okay. Thank you, Dr. Agvanyan. If you have questions about anything that he has presented, please put them in the questions box. It should be in your little control panel that comes with this GoToWebinar presentation. If you can't find your control panel, look for your little red arrow on your screen. And you can open your control panel back up, put in your questions. You can also download our slides from the handouts in the control panel as well. So thank you, Dr. Agvanyan, for that discussion. Now I'm going to let Garnette McLaughlin take the wheel and talk to us about coding. So Garnette, it's all yours.
Thanks, everybody. Just checking if everybody can hear me all right. Fabulous.
Yep.
Thank you. So thank you. You actually touched on a lot of topics and some things I'm going to come at from a slightly different perspective as well. So I'm really glad to see that, again, everybody on this call, we're all kind of dealing with the same issues. We might just have a slightly different perspective on it. So from the coding standpoint, I don't want to say, what's the word I'm looking for? I'm not clinically stupid, but I do have coder brain, right? All my coder friends on the call know that we always kind of say, but what did they say? What did they document? The clinical definition of sepsis, whether using sepsis 2 or sepsis 3 from a purely coding standpoint, doesn't matter. Did you say sepsis? And did you say that consistently? That being said, ICD-10 CM lines up better with the sepsis 2 definition because we do break out severe sepsis as a separate code. So technically, if you really were matching up clinically what those entities were, you would, if somebody was following SOFA criteria and sepsis 3 definition, you would need to assign both codes. But again, in coding land, we base that off of, but what did you say? And I'm so sorry, my technical difficulty. Did I just make anybody dizzy with that? I apologize. And I'm unfortunately not seeing my controls to back up. Denise, would you be so kind to back me up?
I will back you. I will back you up.
Thank you.
Okay, you want the next slide?
That'll be, yep. So we're going to go ahead and move to the next slide. So again, we're talking about, but what did you say? I think some of these are oldies but goodies, guys. I still see documentation and records of urosepsis. Please don't. Just stop. Sepsis syndrome, intermixing of terms of SIRS, bacteremia, and sepsis, and not kind of drawing the line and saying, this patient has E. coli, bacteremia, and sepsis. Okay, that's very, very clear. But saying over here bacteremia and over here sepsis and maybe or maybe not, you got to draw those lines. And also suspected sepsis, as Dr. Agvanyan so clearly and succinctly said, really saying what is the status of that sepsis. They may have appeared septic when they came in. We did the workup. We realized that that's not really what was going on. So making sure that you're very, very clear about that. And I like to say it's like waving a flag to a red, waving a red flag in front of a bull. When you start putting these things in the medical record, an auditor is going to pounce on it. They see it and it is a red flag. And also they present coding problems. For example, urosepsis. It doesn't go anywhere in ICD-10 CM. So if you say that, it is going to earn you a query because as a coder, I have no place to put that. I have no way to classify that. So moving ahead to the next slide, if I can. So I think you mentioned this as well, Dr. Agvanyan. Sepsis documented once. This is one of my coding favorites. Technically, we know from a coding standpoint, that's enough. Once is enough. It's like being a little bit pregnant, right? You either are or you aren't. They either said it or they didn't, and they were definitive or they weren't. It's very clear. But we know that if a payer sees that record and an auditor gets their hands on it, you're going to receive a denial for that. That doesn't represent consistent documentation of the condition. So we often see this where a sepsis alert gets triggered in the ED. And so you see potentially a diagnosis from the ED physician of a sepsis, and then it appears nowhere in the rest of the medical record. As a coder, knowing what I know, yes, technically that is permissible. I am going to query you and say, was this patient indeed septic, now that you've got the whole picture of their stay? So making sure that you're carrying that sepsis diagnosis through the entirety of the medical record, even if it resolved quickly. we've done a much better job clinically managing sepsis, and we're able to, like you said, not wait 6 hours and wait for them to decompensate. That blows my mind. So if it resolved quickly, it resolved quickly. That's fine. We just need to say that. And although I see a trouble spot with concurrent queries from our CDI friends who work so hard to get these things in, they get the query and it's documented as a response to the query, and then it's never brought in into the rest of the medical record. So working with physicians to understand that anytime you receive a query, you want your best practices to pull that forward into the medical record. Sepsis without clinical indicators. These are my favorite, and some CDI programs won't touch this with a 10-foot pole. Some are brave and we'll go here. If you see sepsis documented in the medical record without any kind of corresponding clinical indicators, that does need a query to say, I'm not questioning your diagnosis, I just want you to explain how you arrived at that, asking for their rationale. That's in alignment with all of our coding guidelines and the ethical principles that govern both the HEMA and ACDIS. And as we move to the next slide, our 2023 changes to the official coding guidelines. So our favorite coding guideline, right? Code assignment and clinical criteria. In essence, it says, it doesn't matter how they got there, they said it, you code it. But they've added in 2023 a line here saying, if there is conflicting medical record documentation, query the provider. Now, in the coordination meetings, when this change was being discussed, this was really intended to basically say, if you have a stated diagnosis that conflicts with the clinical indicators in the record, we have a pregnant 83-year-old male, that's a conflict. Or there's just nothing there. That's conflicting. And so that's a question that needs to be asked. So that has now been embedded into the official guidelines for coding and reporting. So that is something to be very aware of coming up. And I think most people, as a best practice, had already been doing this, but now it's in writing. So this is where, as Dr. Agvanyan said, physician education really, really plays a role. So letting them know why are they getting queries? We're not questioning your clinical judgment. We're making sure that you're clearly conveying that, right? There are a lot of consumers of the medical record. It's not just other providers or yourself in this singular encounter, right? Post-discharge care across the continuity, coders, the patients themselves with portals, auditors, both internal and external. And we know that we don't always approach things with the same base of knowledge. So we want to make sure that we are being clear. Auditors are motivated to find the problem, and they're gonna, so don't leave it open. Don't give them an opening, right? It's like when you're arguing with your significant other, don't give them the opening, you know. So again, it just comes back to the English language. The English language is not the most clear and precise thing out there. What I say right at this very moment and what I think I'm conveying to you as an audience may not be what you're hearing and taking from me. And that's just the nature of the English language. So queries can help you clarify that for others who might read the record as well. Complicated sepsis, I had to bring this up. I see this documented, and usually when I see this documented, it's in reference to sepsis that's related to like a complication, a device, a transplant, or a procedure. So making sure you're working with physicians that if a sepsis is due to something like this, that we're getting very clear documentation of it. Sepsis due to UTI, patient with indwelling Foley always makes my skin crawl a little bit. It's going to prompt us to ask you, is that UTI as a result of that indwelling Foley? It changes the coding, the sequencing on it. So we want to make sure that we're getting that correct. Another arena I always see is a little bit of under-documenting. We're kind of underselling what's going on with our patients. So making sure that we're accurately representing and then therefore coding what is going on with this picture. So linking the sepsis to any associated organ dysfunction, so you can add that severe sepsis code. And again, show the picture of the severity of this patient's illness. Make sure you're including even the more subtle signs of organ dysfunction, right? Severe sepsis is organ dysfunction, not necessarily full-blown organ failure. So it still counts though. we know that this patient is heading that direction if we don't intervene. So if we're seeing an elevated troponin due to sepsis, no, they maybe haven't had a full, type 2 and STEMI, right, due to demand from their sepsis, but they are showing organ dysfunction. So we want to make sure that we're showing that. And again, not underselling the severity of this patient's condition. I see this one a lot. Patient with sepsis admitted with hypotension. They've got an elevated lactate. We can't get the pressure up with fluids, and so we're going to put them on pressors. Is there septic shock here? So again, making sure that we're capturing all of those things that come with it, because that gives that full picture. And so when you're going back to a payer, you can say, here's where we see the multi-system impact of this presence of sepsis. And so just an excerpt from coding guidelines. So when you do that, if you tell me that I've got organ dysfunction associated with sepsis, I, as a coder, can automatically assign that second code for severe sepsis. That is by guideline that I can do that. As Dr. Agvanyan mentioned earlier, having a developed policy is another arena where this is really going to help you both in your consistency of documentation and then down the road. Coding clinic and coding guidelines allow us to develop a specific policy for how we address and document sepsis, how we identify and define it. Again, though, having that policy doesn't alter the final coding of sepsis. We're going to come back to that, but what did they say? So it helps you, though, to build a shared understanding of how you're defining sepsis and when you're going to say the S word. And I think we talked a lot about this too, is earlier speaking about the contracting and some payers adopting sepsis 3 versus their internal use of sepsis 2. By coding guidance, that is permissible. A facility or a payer may require that a physician use a particular clinical definition or set of criteria when establishing a diagnosis, but that is a clinical issue outside the coding system. So unfortunately, the coding system is not going to help us out here. It is intended to basically, again, but what did they say? So it's difficult to come at things from a coding perspective when you're arguing with a payer with this rule, knowing that this is out here. So that's where, when he was talking earlier about contracting and making sure that you're negotiating with your payers in advance, that you're agreeing upon what your definition is. And so making sure that you're really working closely with your contracting folks is going to be absolutely crucial to doing that. And then utilizing your external appeal rights. You just absolutely have to do it if that's available to you. Obviously, again, auditors and payers are incentivized to find fault with you and to reduce your payment. They have a financial incentive to do so. So if you can get a third party involved, whether that's an external review organization, if you're talking about Medicare and administrative law judges, being able to then take that documentation you've built. We've said repeatedly, this patient has sepsis. We documented all of these associated organ dysfunctions. It's very clear from this documentation that this patient is septic. You're going to be able to present that to that person who's less invested and have much greater likelihood of a good outcome. And you always just, again, you want to take each case individually too and make the best argument you can. So your documentation is going to be critical to being able to make each individual case, because in the end, it's about the patient, right? Providing the care that they need when they need it. And we want to make sure that we're accurately reflecting that in the documentation and in the coding. And if we do that, we should be paid for it. So that's how that whole kind of spectrum falls across. So those are a lot of different things that I know we just talked about, but things that just immediately come to my mind whenever somebody says, Garnette, can you talk to me a little bit about sepsis and coding? Sepsis and coding is always kind of challenging, not so much from that technical coding aspect of it, but the documentation piece of it, and the interplay with documentation and the patient's clinical pictures, really what makes it challenging. So working closely with your physicians and your physician advisors and having that shared understanding really does absolutely become crucial to your success.
All right. Thank you, Garnette.
Thank you.
Up next, Christi Drum, and Christi's going to talk about clinical validation. And I think you have control now, so it's all yours.
I'm not able to advance the slide, but I did just want to make a couple of comments on Garnett's last slide here. Basically, I just wanted to piggyback on what's already been said in terms of clinical criteria and how important it is to start having, if you haven't already, or to continue those conversations with your CDI and your physician advisors and above, that you know, we see or we hear from a lot of organizations of, well, you know, kind of exactly what Garnette talked about, that, well, the physician documented it, so it should be coded. But as Garnette mentioned, there is this clinical validation piece out there that, you know, according to the new guidelines that are coming out, can't be ignored. And so we have to really have a proactive approach about having those conversations with our physicians about, you know, making sure that what is documented is clinically validated. Otherwise, it becomes a huge target for payers to deny those diagnoses. And so I just think it's crucial to have those conversations up front about your clinical criteria, even if your organization isn't going to have a predetermined set of criteria. You have to be having those conversations of how are you going to approach your documentation, and then how are you going to do it on the back end for your denials in terms of defending what's been documented to be most successful. So I'm going to give a couple of examples about how we approach it at PayerWatch. And I think Garnett's statement, we talked a little bit about this before the webinar, is making your best approach. So even if your facility doesn't have a particular defined definition of sepsis, and your facility or your organization hasn't predetermined, like Adventist has, hey, we're going to use sepsis 2, or hey, we're going to use sepsis 3, that you, regardless of what criteria your facility has chosen to use, or you haven't specifically said this is the approach that we're going to go with, you have to make your best argument, whether you're going to use sepsis 2 or sepsis 3. You just have to make your best argument to defend the diagnosis of sepsis, regardless of the criteria. So let's see if, all right. So I'm just going to go through 2 case examples, and before I go through them, just a little background about both of these. They both were overturned successfully. So the first one is going to be in reference to a case that we defended for sepsis 3, and then the second one is going to be for sepsis 2. So this was the auditor's rationale for denial. I'm not going to read it. It's pretty lengthy, and I think it's actually one that folks see very frequently. We see these all the time. And this payer has denied based on sepsis 3 in the SOFA scale. And so we wrote an appeal based on SOFA criteria, and this particular patient met SOFA criteria. And so this is actually what came back at the second level. And I wanted to point out the second paragraph here, which I think is something that is pretty crucial, that when you get these back at subsequent levels, you have to be sure that you're addressing all aspects of the payer's rationale and making a rebuttal for each of them. And so the second paragraph says, in the setting of pneumonia, hypoxia, or the PF ratio in this patient is a manifestation of the infection in the lungs, and therefore not evidence of dysregulated immune-mediated organ injury. While we acknowledge that the patient had an elevated creatinine that rose to the level that satisfies sepsis 3, this alone would not validate the diagnosis of sepsis. So there's actually 2 issues going on with this patient here in terms of what the auditor has said. First off, they've denied the patient's hypoxia that they had as evidence of organ failure. So one of the things that we write heavily on in looking at the the infection that the patient has is that not all patients that have a localized infection will have signs of organ dysfunction in that same body system. So if a patient has pneumonia, not all patients with pneumonia are going to show evidence of hypoxia or show evidence of acute respiratory failure. So if your patient does, then it's crucial to point that out, that your patient is having a hypoxia or acute respiratory failure, and it shouldn't be negated or ignored, and that should be definitely used as a rebuttal for the auditor's rationale. The second portion of this is that they wrote, while we acknowledge the patient had an elevated creatinine that rose to the level that satisfies sepsis 3, this alone wouldn't validate the diagnosis. So they've already admitted that the patient has an organ dysfunction in the renal system that met the sepsis 3, but then they're saying that that alone doesn't validate. And so the second point is making sure that you really understand sepsis 3 and the SOFA criteria, which requires that a patient has a SOFA score of 2 or more above the patient's baseline. So if this patient meets it in one category, the patient meets SOFA criteria. The criteria doesn't say that you have to have it in multiple categories in order to represent organ dysfunction. It just says you have to have a score of 2 or more above baseline. So it's really making sure that you're looking at the auditor's rationale and picking it apart piece by piece, and then using that at your second level or your first level or your second level, and doing pointed arguments to say, you wrote this, but this is wrong, and you wrote this and this is wrong, and this is why. And you can even do that using the references that the auditor themselves has referenced. So if they're saying something and referencing an article or the sepsis 3 or even sepsis 2 criteria, and they're quoting it incorrectly, be sure that you're pointing out that they're quoting it incorrectly. So here's a snippet of how we wrote the rebuttal to the auditor's claim for the denial. And you can see at the top here that we pointed out specifically how did the patient meet SOFA criteria. And so this patient had a score of 1 in the renal category and a score of 2 in the respiratory category. So we were sure to point that out and say that the patient had a total score of 3. So by definition of meeting the SOFA score, the patient had 2 or more above baseline. And then the paragraph underneath that goes into more detail about the auditor's claim that hypoxia can't be considered. And I kind of already touched on that, basically that the hypoxia in this patient is a manifestation of the infection in the lung, and therefore not evidence, that's what the auditor wrote, not evidence of dysregulated immune-mediated organ injury. So we said that statement's false, and it's a complete misrepresentation of the sepsis 3 or the SOFA criteria, and that organ dysfunction with the same body system as a site of infection can it shouldn't be negated. The hypoxia isn't inherent to pneumonia, so not all patients with hypoxia have pneumonia, and not all patients with pneumonia are going to have hypoxia. And so as such, the patient did meet the SOFA criteria. And then additionally, we also came at it from a sepsis 2 approach. And that's something that we commonly do with our sepsis denials if our client does not have a predetermined criteria that they're using. So if they haven't said for their facility, hey, we're going to go with sepsis 2, or hey, we're going for sepsis 3, we'll incorporate both of those in our appeal letter and say, hey, this patient met sepsis 3 criteria based on this, and the patient also met sepsis 2 criteria based on that, and therefore we feel like it's a valid diagnosis and it should be reinstated on the claim. So kind of going back to making your best argument. So if your patient is meeting both criteria, there's nothing wrong with stating in your letter that the patient met both criteria. Just make your strongest point. So as mentioned before, this was overturned for full repayment on this claim. All right, here's our next example for sepsis, and this one the auditor's rationale for the denial said that according to clinical validation criteria, in order to confirm the diagnosis of sepsis, you have to have consistent documentation, which is kind of what Garnette had already talked about, and evidence of life-threatening organ dysfunction caused by a dysregulated host response to infection, the same as what we've been saying. Although I do find it interesting in this auditor's denial rationale, they didn't specifically say that they were using sepsis 3 criteria. They hinted at it, but didn't say, hey, this is what we're going to use. And we do see that quite frequently where they're going to use sepsis 3 criteria, but they're not actually saying, hey, we've adopted as a payer and we're using sepsis 3 criteria. But that obviously is how they denied this case. So for this particular example, the patient did not meet sepsis 3 criteria. So we, again, took our best approach and came at it from a sepsis 2 criteria. On the left-hand side of the screen, these are snippets from how we write our letters. And at the beginning of our letters, we highlight portions of the medical record that we felt were pertinent to the diagnosis that's being denied. And so I incorporated a snippet here from the patient's H&P that very clearly goes over the SEP2 criteria, talks about patients' vital signs, heart rate, respiratory rate, elevated WBC. But then the reason why I incorporated this is because the physician clearly says how he came to that determination of sepsis. In the assessment and plan, he says sepsis secondary to bronchopneumonia, sepsis physiology met with the WBC of 17, heart rate greater than 90 in the setting of bronchopneumonia. So we are very careful to incorporate that anytime our physicians outright state in their documents, whether it's the H&P or their progress notes, how they arrived at that documentation or how they arrived at that diagnosis, and then we incorporate it in our letters and say this was the provider's clinical judgment, this is how he arrived at the definition of sepsis. And then interestingly enough, as Garnette mentioned, we also try and look for any other evidence of organ dysfunction, not necessarily organ failure like she mentioned, but organ dysfunction. And you can see about 3/4 of the way down, he says elevated troponin or likely elevated in the setting of sepsis. Now, obviously it's not a definitive documentation there, and we would need to look for it further on, but it's worth pointing out to your auditor that the patient has something else here going on, perhaps organ dysfunction in the cardiac category that is related to the patient's sepsis. And then so on the right side of the screen is just the narrative that we wrote, basically supporting that the provider documented exactly how he felt that the patient had sepsis, and that it is based on his clinical judgment, not necessarily the auditor's arbitrary criteria, and that the provider is seeing that the patient in real time and knows all of the different comorbidities and everything that's going on with this patient, and that should not be ignored. The second paragraph is something that we frequently put in our denial letters that we feel is pretty important, that, and I think we kind of touched on this today, and I know it was probably touched on last week, that there really is no consensus-based criteria that's been adopted by all agencies or all organizations out there. Dr. Agvanyan, mentioned that CMS goes with sepsis too, and so that's what they use. But other organizations, whether it's critical care organizations, ER physician organizations, not everybody's adopted this sepsis 3 criteria, and so we point that out in our letters, that it hasn't been adopted by everybody, and that it's really just one possible piece of information that can be used to derive or come to a diagnosis of sepsis. And so I think that's also important in pointing out to your auditors that that's great that you use that, but not everybody else has adopted it. So we kind of go at that with that approach as well.
Christi, let me just toss a quick question.
Yeah, go ahead.
To the coders and the physician advisors. How do you incorporate or sidestep the use of sort of colorful language? For example, patient appears toxic versus at the end of the ER summary, patient appears stable and okay for admission. It's obviously a 50,000-pound elephant that sits in a lot of these. Is there any thoughts on how to address these non-codable words that might add impact? Is it worth acknowledging them, ignoring them if they don't help, bringing them forward if they do? or any thoughts one way or the other?
Well, I can speak to that a little bit. The approach that we take is, we've now had our physician advisors, meet with our ED service lines. We have a system ED service line, and where all the ED physicians and the medical directors meet, and we try to address it in this area, because the same thing has come up, with our chief hospitalists who have to do the denials, or the PAs that are doing the peer-to-peers, and having to fight a plan that's saying, well, your ED doc said, patient doing better and stable, so why are they being admitted, right? Well, why are you calling it this? And so, and when we talk to our ED physicians, their justification comes more from a fear of medical malpractice, and so the documentation of that, sort of, oh, patient is stable and doing better. But we have to explain to them that, and it's a continuous education, that if you're admitting somebody to the ICU, or if you're admitting somebody that seems complex, they're very complex and toxic, you should not be putting better. You should state how the patient is, and it's not like you're discharging them and saying they're toxic, you're admitting them, right? So, state it as such. I think they're just in the habit of putting that as a sort of, we stabilize them and they're better now, so we're moving them to the next level. So we're just trying to teach our ED docs to not put those things in their documentations.
Gotcha.
I think from the appeal perspective, probably how I would approach something of that nature, saying that's after some initial management in the ED. We see fluid boluses, we see treatment given and initiated for it. So yes, we may have seen improvement in the ED, but that does not by any means mean that their treatment is completed and they're out of danger. So I think from an appeal perspective, that's how I would approach something of that nature, is just kind of saying, well, yes, they're better because we initiated management early. We identified and moved forward with management early.
And I think one of the things that Dr. Agvanyan mentioned earlier is education to your providers about the danger of copy and paste in your documentation, or the danger of documentation by exception only, where your EMR auto populates a regular narrative and the physician or the provider is responsible for going back and deleting and putting in what's abnormal. And so if you have an EMR that uses that and pre-formulates, heart rate, regular rate and rhythm, or whatever, things of that nature, you run the risk of, if patient stable is part of your normal assessment that pre-populates in there, and the physician isn't going back and removing that and putting how the patient is actually presenting, then you're setting yourself up for failure on the back end when it comes to a denial. So I think that's a critical education piece and something to think about if that's how your EMR approaches documentation. And the role of CDI going back and educating providers on, hey, this is really a piece that has to be focused on. So with that in mind, this last case example that we went over was one that you're fine, Denise. I was just going to add that this was a case that we actually had to take to peer-to-peer. It was denied at all internal levels, and we were able to take it to the external level to a peer-to-peer, and it was overturned at a peer-to-peer. So I know Garnette had mentioned in one of her last slides the importance of, and I know that we've talked about this in numerous webinars, the benefit to getting outside of your internal level of appeals and exhausting all of that so you can get to something external to a neutral person who can evaluate it from a non-biased perspective. And so this case was done at a peer-to-peer with one of our physician advisors, and as Dr. A mentioned, with another physician who was open to conversation, of having that conversation of, hey, if this were you taking care of this patient at the bedside, can we both agree that we both would have called this sepsis? And that is in fact what the patient had, regardless of a sepsis 2 or a sepsis 3 criteria. When you look at the patient's whole clinical picture, the patient really did have sepsis. So it was overturned at a peer-to-peer based on the sepsis 2 criteria. So I guess the bottom line is, from an appeal standpoint, whether you've adopted sepsis 2 or you have adopted sepsis 3, you really just have to put your best foot forward, taking out all these critical pieces in your medical record and making a holistic presentation of how sick the patient really was, and incorporating that, and really picking apart the auditor's denial rationale with a fine-tooth comb and showing all the errors and what they've done, whether that's at the first level or the second level or whatever your internal levels are, going all the way to an external appeal. So that's kind of how we approach sepsis from a denial standpoint.
I think that's really well said, Christi. And I think the other thing, especially in a case like this, where you may have an auditor who's really wanting to mix together SOFA or QSOFA scoring and defining sepsis. SOFA and QSOFA as a calculation, they're ICU mortality predictors. They were never intended to define a diagnosis of sepsis. So making sure that you're bringing forth that, if the auditor is bringing in that rationale as well and saying, well, their SOFA score is this, well, that's a mortality predictor. That it's not a definer of sepsis, and it was never intended to be used that way. So they're abusing that criteria. So making sure that you're really honing in, and if they're saying something like that, your understanding of the definitions of sepsis and the clinical criteria versus, say, a calculated scoring method, and where that comes from and what it's really intended for is going to be critical in, how do I like to put it, shredding the auditor. That's what I like to call it. So that's another piece I will put out there is, again, you see that over and over again in these rationales where SOFA scoring is being absolutely abused for what it was never intended for.
Totally agree with that.
Like using an Apache score to define anemia.
Yeah. Mind blown.
So for our folks on the webinar, we are going to stay an extra 15 minutes to answer some questions that you all have entered into the questions box. So I just wanted to let you know, I know some of you probably need to jump off at the top of the hour. I know how meetings go in hospitals. But I do want you to know that if you can stay on for the next 15 minutes, we're going to go through some of the questions that you all have asked. I just want to make sure I get that out there. But you guys, you're having a great discussion. I hate to interrupt you because you've got a lot of good things to say about this topic. So let's start with a few questions. Talking about, that was interesting, Christi, when you said about getting on a peer-to-peer and speaking with a physician on the other end who kind of gets it. Because the first question in our list is, can you request a specific physician during your peer-to-peer that has a reputation for being reasonable, even when the payer embraces sepsis free? So I don't know if that was a serious question, but I'll let Dr. Smith or Dr. A.
The odds are they're not going to be working there long.
Well, I will comment on that. We do have a situation like that. For example, the medical director of a particular payer, although it's a small market, again, goes back to our Hawaii market. So our medical officer at the hospital will always contact the same medical director of that plan, because they've formed a relationship with some of the peer-to-peers they've done, and she is very reasonable. And so that's been his approach, and he's been single-handedly responsible for several $1 million of overturns within the last year from upheld cases that Kendall's been sending me, that were egregiously denied through an auto denial loop or whatever it did. But it took us getting, the medical director on the line, and when we were able to and showing them the evidence that exists within the clinical record, we were able to get some of those. So you can have that if you have a close working relationship with the reasonable payer. And, I would just say, when possible, create joint operation committees, right, with these payers, get to know the medical directors. They're not going to be unreasonable, but for the most part. And once you have a working relationship with them and it is a contracted facility, it's important for them as well. So if you're reasonable and they're reasonable, keeping the lines of communication can go a long way. So.
Great. That's good to know. Okay, I believe this one was meant for Dr. Agvanyan. Are your overturn denials coming primarily from peer-to-peer reviews or through the back end of sending your appeal letters? Do you have a sense of how much you get overturned on peer-to-peer versus how much you get overturned
I
through
don't
the
have a
appeals process?
I would say both, right? So we get a significant amount of overturns from appeal masters and the appeals that are sent on our behalf, and we do utilize appeal masters, right? And Dr. Smith is helping us out with that. And on the back end, when egregious denials continue to be denied and they're upheld on a second appeal, then we utilize a peer-to-peer. Concurrently, we heavily utilize peer-to-peer.
Another question, how do you obtain commitment from the physicians to participate in the educational process, or are you educating mostly just hospitalists on your sepsis?
We're doing both. So in some of our markets, it's heavily hospitalist. About 80% of the volume that's being admitted is with the hospitalist. The hospitalist, organizations that we contract with are obligated, to us for performance, so it's easy to get them. But we have several markets where we have about 50% of the admissions coming from community physicians. Those have been challenging, but what we've done is we've created on-site dinner events, and we've worked with the medical staff office, the medical officers, the presidents, and of those facilities in getting those providers to come to some offsite meetings, because we know that on an on-site they may not attend. But a nice dinner presentation at a steakhouse, we did that in Glendale. We're doing that in our White Memorial Market. We had a very significant attendance and all participated very well in asking questions, and that's where we've seen some of the improvement. So
I think one other thing that really helps in that arena is making sure that you're not, how do I say this, coming at them from all directions. They have somebody in compliance coming at them and saying, I need you to do this. Somebody from CDI coming and I need to do this. So the more unified an approach that you can have so that you can boil it down to the salient points and really respect their time has a great, it's a lot of work to do it that way, but you're going to see better success if you are able to sort of present a unified, cohesive, one-time kind of thing, rather than somebody from CDI, somebody from compliance, somebody from coding and rev cycle, all approaching these physicians. They have a lot of demands on their time. So anything that streamlines that is going to be appreciated.
I agree.
And I was just going to say, I think also boiling it down to making it personal for that physician or that physician group on how that affects them, that, if their cases specifically are involved in denials, or their documentation is specifically involved in denials, or making that clinical validation complicated, how that ultimately is going to affect them. I know Dr. A talked about case mix index. Well, that's all revenue for the hospital. So if you're having lost revenue, whether it's, a specialty group in the OR or a community hospital, lost revenue means lost resources on their level. So personalizing it and really showing them how the lost revenue is going to have a trickle down effect to where they're at, whether it's in a community setting or in the whether it's you don't have the most up-to-date supplies that you want in the OR because we're having that revenue loss or take back. So making it personal, I think, is important.
And
Yeah,
come with the data. Yeah.
We've done a lot of that, and then we've made sure to separate the specialists so that we're not mixing in surgeons with hospitalists during these talks, so it's relevant, specific to what they're doing. And then the other thing that's really helped us is we've strategically selected our physician advisors at each market to be working physicians in those markets. So they're all on the medical staff. These are all colleagues. These are people that they work with. This isn't somebody coming out from outside that they don't know. And that's been really helpful when it comes to the one-on-one education for those providers that don't come to these dinners, because they're very receptive to just sitting down with a colleague and having these conversations from somebody that they work with and respect. So.
Yeah, I think, Edgar, my experience with CDI and engaging physicians has been the awareness that it's not only CMS that's got physician ratings, but UMR, Anthem, for example. You can, if you want to get a brave volunteer from the audience, it's often interesting to go to Anthem's website or UMR's website and do a live lookup and see how many stars their practice is rated as. It's based on quality, readmissions, cost per case, and certain metrics that they set forward. But some of it's related to hospital care for those that are providing hospital care So from the standpoint that they don't think this data is going to impact their practice, you get a tier 1, tier 2 rating on a United as a United provider. I'm going to go see the tier 1 doctors just out of financial necessity, because I don't want a 40% copay seeing a tier 2 doctor.
Right.
So this is very translatable as to the mouth to your practice's success. And to me it's really eye-opening, because I never really had realized the extent to which data is kept and used to create these networks.
Yep, definitely.
Okay. Next question. Should we be careful to have our physicians document that sepsis was ruled out if the patient's sepsis signs and symptoms were stabilized in the ED with supportive care?
I mean, if it's been ruled out, it's been ruled out, right? So if you're not going to be able to carry that forward into the following day's progress note, and your admitting physician is not going to be calling it sepsis, and your discharge summary is not going to be calling it sepsis, more likely than not, that's going to be denied. And so I would say that if it's been ruled out, you need to document it as such.
Yeah, or resolved if that was the case.
Right, or resolved.
So. And they were indeed septic, but it was very well managed and was able to stop that pathway from continuation. Documenting that resolved versus the ruled out becomes very, very important. Yeah.
Okay. Question about queries. If the only documentation of sepsis is from a concurrent query, do you recommend an additional query at discharge?
I would say that it would depend on how consistent the documentation is. Like Garnette mentioned, if sepsis, and this is, I find it interesting, my approach in the CV land changed drastically when I went from CDI to denials, because, in CDI, you query just as, the person posed a question and you got sepsis and it was documented one time, you think you did fantastic, but that's an auditor's dreamland, is for you to only have a diagnosis mentioned once. And so, Garnette hit on this. I mean, if it's only documented once, it can be coded. And even if it was clinically validated, that's great, it can be coded, but we see a ton of denials for, well, it was only documented one time and it was never mentioned again, and it wasn't carried to discharge, although we know that's not necessarily a requirement, but it makes it very difficult to defend on a denials perspective if the only mention of sepsis in the entire record is from the query that you generated. And I think my colleagues will agree that it doesn't matter if it's a concurrent query or a retrospective query. I think maybe even more dangerous as a retrospective query, because then you get the response from the auditors of, well, how come nobody bothered to mention that in the entire medical record? It must not have been that important. The patient must not have been that severe if nobody bothered to document that. And so is it the end all be all? No. Can you appeal it? Yes. Can it be coded? Yes. But if you want to set yourself up for best success and at denials prevention, which I think is, all of our goal, then ultimately having it carried through to the documentation is optimal and best practice from a coding standpoint and from a denial standpoint.
Yep.
Yep. And whether or not you re-query it retrospectively, it would really depend on how your particular facility wants to approach something like that. Some facilities will elect not to do that again, and some will. So it's worth having a discussion with your CDI team, your physician advisors, and the med exec committee potentially to really say, this is what we want to do and be in agreement, because that's going to be critical in cases like that if you feel the need to escalate something of that nature.
But again, I think it comes down to education as well, that those have to be talking points from your CDI department or your physician advisors, whoever it is that you use, that a one-time documentation is very difficult to defend. So education goes a long way where that's concerned.
I would say if you have like singular hospitalist rounds or MDR rounds, get your CDI folks to participate. That's something that we've been working on for the past couple months. And what we're finding is that they're having live discussions with case managers and the physician. And so they're rapid rounds, but any questions that come up about the DRG, what's set, what the working DRGs, and what the limitations of the CDI team are when it comes to length of stay and things of that nature are answered immediately. And it's sort of daily education that you can't find anywhere else. And so the need to query is eventually going to be reduced significantly, and you can concentrate your efforts elsewhere. So
that's a great point. Actually, one organization I worked with included a senior level coder as well with their CDI professional, and the learning that took place when all of those perspectives were in one spot in a live case was absolutely critical and valuable, and I think everybody took something from that, just in terms of understanding everybody's different approach and how they're looking at things.
Okay. Next question. It's worded in a way that I think I'm going to kind of explain, I think, what they're asking. What are the results for arguing sepsis 2 when you only have sepsis 2 documentation in the record, the patient only meets a sepsis 2, with a sepsis 3 payer when it gets to peer-to-peer external review or a judge? So my thoughts, I'm just going to interject kind of my thoughts on this, and then let you guys talk as well. I think what they're asking is, why are we saying that you have, you may have better success arguing if you can get it outside the court of the payer's opinion, outside of the internal review process. And that's because when you go to external review, you go to a judge, and possibly even peer-to-peer, or doctors can address that piece of it. The adjudicator on the other side, meaning that person who's in charge of performing that external review, or that judge, is not constrained by following exactly a protocol that is set out by the payer, a list of check boxes that the payer says has to be checked before we're going to pay this claim. They have a little bit more relaxed rules that they can make those decisions on, and don't have the constraints that the payer reviewers have. So that's my opinion on that. That anybody else in the group that wants to chime in as well.
I would just agree with everything that you said, Denise, and just as difficult as it may be to admit, the folks reviewing things for the different payers, like you said, they have a checklist, or they have, only, deny this, and this, only allow this, and this. And unfortunately, it doesn't always allow for thinking outside of the box in a clinical picture. And we all know that each picture or each patient doesn't fit necessarily in a certain set of criteria or in a predetermined box, that each patient should be evaluated in and of themselves, the comorbidities that they have going on. I know, like, for example, one of the things that Kendall likes to talk about is a patient who, is on a beta blocker, and they come in with a heart rate of 90. Well, a patient who comes in with a heart rate of 90 on a beta blocker, they have an elevated heart rate for what their normal is. But if you're going off of a set criteria of you have to have X, Y, and Z, well, that patient might not necessarily meet that particular criteria. But, there are all sorts of other factors. Medicine is complicated. And so I don't think you can look at, a checkbox or certain criteria and deny or, allow based on that. It is complicated. And so that's why we say getting in front of somebody who, isn't confined to a certain set of criteria or a certain set of check boxes, and you can have a realistic conversation of yes, but, and take into consideration all that's going on with the patient, I think allows for a greater success.
Yep. These are people and patients, not policies. And a lot of these outside adjudicators are able to see that, especially if that's how you present your argument. Yeah.
Okay. Very good. So we have a ton of questions that came in from this webinar, as well as our webinar workshop from last week. So our plan is to kind of cull all of these together and come up with some good talking points, some good answers for everyone that we will be able to share and post on our websites once our workshops are done. These have been great because y'all have, this is the top thing that we're all dealing with, and all of your questions have been great in helping us kind of help you and educate you on some of the best practices in dealing with these. So I want to thank Dr. Agvanyan again for being our special guest today. Appreciate your thoughts and having you on. Christi and Garnette, thank you so much for your presentation. Dr. Smith, for your input as well. Don't forget to sign up for next week's presentation. It'll be our last workshop on sepsis, and that's going to be on Wednesday next week. You can register at www.PayerWatch.com. Thanks, everyone, and we will see you next week.
Bye-bye.